Major funding for these broadcasts has been provided by grants from New York Community Bank, Capital One Bank, Eastern Consolidated, M&T Bank, Sterling National Bank, Meridian Capital Group, Customers Bank, Aerial Property Advisors, Perfect Building Maintenance. Additional funding has been provided by AKA Hotels, Corman Communities, AmTrust Title Insurance Company, AVR Realty Company, Avison Young, Bank of America, Merrill Lynch, Bank Leumi USA, Briarwood Organization, CBRE, Chase Commercial Term Lending, Chase Mortgage Lending, Citizens Bank, Cohen Equities, Colliers International NYC, Collins Building Services, Connect One Bank, CPEX Real Estate Services, Dime Community Bank, Douglaston Development, Levine Builders, Flushing Bank, Friedman LLP, Genova Burns, Handro Properties, Handler Real Estate Organization, HAP Investments, Hodges Ward Elliott Inc., Investors Bank, James D. Kuhn Real Estate Center at Syracuse University, Kilroy Architectural Windows, Madison Realty Capital, Matone Group, Mercantile Bank, New Banks, Newmark Grubb Knight Frank, Optimum Window Manufacturing Corp., People's United Bank, Polsonelli, Rosewood Realty Services, SJP Properties, Stonehenge Partners, TD Bank, Terra CRG, the Knackle Group at Cushman & Wakefield, Maring Goff Family Foundation, the Moynihan Group, and these friends.
Each and every day you pick up the newspaper, all you hear about is healthcare, insurance. You hear all these problems. But what's really happening, and how do we resolve the problems, or are they resolvable? So today I've brought these established senior executives from the healthcare world to provide their insight on the healthcare market and what we can do.
Veterans.
Okay, Harvey. Yeah. My first veteran is Dr. Michael Stocker, a veteran who is the immediate past president and CEO of Empire Blue Cross and the past chairman of the Health and Hospitals. Tony Ferreri, who is the past president and CEO of Staten Island University Hospital Northwell Health System, also took care of major acquisitions for them in Westchester and Putnam County, and also was involved with Lenox Hill. And last but not least, the elder member of our group, the man who was with the Amalgamated Insurance Company, Multiplan, who is now a senior advisor to the Riverside companies, the eminent Harvey Sigelbaum. So, Mr. Sigelbaum, you wrote an article in 1988 that appeared in the New York Times about universal health care. We are in a nightmare. We don't know. Each day the premiums go up. Doctors don't take coverage. How do we resolve our problem? So what did you write in 1988?
Well, I pointed out something that we all know, and that is that this country pays, like, on average, about twice as much of all the other industrialized countries in the world. We don't necessarily have the best outcomes, but we're paying twice as much. And all those other countries, every one of them, has universal coverage. The idea of bringing everybody under the coverage tent makes good social sense and good business sense.
But how do you get the doctors and the hospitals, the providers, and everybody to be part of universal health care?
Yeah, well, we really have a unique system. All of us here know that. Almost every industrialized nation in the world has some kind of universal coverage, and we don't. And I think it's really because of our character. Somebody once said, not me, that our Constitution talks about life, liberty, and the pursuit of happiness. And yes, we pay 17% of our gross national product for health care. And I think an economist would say Yeah, but it's a rich country, and if they want to spend 17%, fine. Well, England spends 9%. That will come to an end. It has to. And so I think we have to wait. I mean, the real problem is in healthcare, nobody's in charge. I think we have to wait for the current drama to go through. I mean, one thing is that people in this country are now much more familiar with health insurance than they ever were before because of all that's been played out.
I mean, the cost of health insurance is so expensive. I mean, Tony, when he was with Northwell, one of the initiatives that Northwell did was they went into the insurance business. Why'd they go into the insurance business? Why do healthcare systems do that?
Well, they went into the business to control the dollar. And, you know, when Michael Dowling first approached this with the Northwell system and its board to talk about it, he talked about how the insurance companies were in the business of making a profit, which is perfectly understandable. We're in a nation where free enterprise is important. And he felt that if we controlled the dollar and we could spend more of the dollar on actually providing health care, as opposed to spreading that dollar amongst shareholders and make it more accessible to the stakeholders. That was the thinking behind it. But it's extreme. We've been wrestling with this, not just on the insurance side of this, but we've been wrestling with the cost of healthcare and access for 70 years in this country, and probably longer, but more documented over the last 70 years. Access is the issue. Affordability is one of the reasons why we are wrestling with this so much at this particular point.
Since all three of us are considered baby boomers, I mean, when we were first starting out in our career, you know, people only knew about Empire. They knew Blue Cross Blue Shield. There was terminology, major medical. After you met a deductible, you had a certain amount. Health, and it wasn't such a prohibitive amount of your salary that you'd have to pay. You know, many companies paid for the entire coverage. What has gone wrong, and how do we possibly resolve it?
That's a good question, because also at the core of this thing is, we all know rates reflect experience. So you're talking about the underlying costs, and your question is about the underlying costs. So where has American healthcare gone from a delivery point of view? And what are the issues there? Is it the fact that we become so specialty-centric? Are they specialty-centric in the UK or in France or in Canada? And is that part of the problem? Is it the fact that every hospital has to have the latest in machinery, even though you can go across the street and get the same work done on a machine that's not, you know, working all day long? Are we wasting money there? I mean, so what do they predict, that 30% of healthcare is wasteful? Is that the figure that's used?
Yeah.
And so what do you do about that? So so it's not just about coverage, it's also about delivery.
If you look at other countries, they make very judicious decisions about what they're going to spend their dollar on. And when they do, they try not to be duplicative in terms of where the services are. Here, our hospitals compete with each other. So if somebody gets technology, then all the other hospitals have to get the same technology, even though one set of whatever it is, it could be enough, or maybe two for the whole service area. We just are addicted to choice. I mean, it really is. It's part of the national, it really is part of the national character. If you want to go 1,000 miles to get a regular physical exam at the Mayo Clinic, then you go 1,000 miles to get your physical exam there, whatever the outrageous charge that would be. So I think the two things that would be important is, one, we've got to get through what's going on now, and we just have to. And if that fails, then it might.
Do you scrap Obamacare? I mean, what, you know, how do we take care of this? I mean, the premiums for people, the deductible that people are paying, they can't afford it. How do you resolve this today? Okay, people each and every day say, I don't know. You know, maybe I should be uninsured because, you know, the social system will take care of them if they go into a hospital because they have the poor pool, right?
And that's a good point, because everybody should realize that every American is paying for the health care of every other American, whether we call it universal coverage or not, but in the most inefficient way. The most inefficient way to get your health care, as I'm sure Tony will tell you, is in the emergency room. But we're all paying for it because what does the hospital do? You shift the cost over.
Right. If you want to see, for example, if there is a doctor, and I live in Staten Island, and there isn't a private practicing physician in Staten Island who accepts Medicaid patients. But if you want to see that very same doctor, that doctor will be working in the clinic at the hospital where he's paid by the hospital to see the same patients. So it is a system where people do have access. But it's a system that's really been put together with a lot of tape and...
Right.
And so how do we get the bubble gum out of the system?
There's a couple fundamental principles about insurance. The one is, you know, we always want insurance. Well, if you have a lot of health problems, then you got to pay a high premium, and if you're young, you don't pay much because you're not going to use many services. But the way insurance is supposed to work is when you're young, you pay the same premium as everybody else pays. And so when you get old, your rates are not so high because the young people, you know, it's a part of being a, you know, it's a part of being part of the country that works to help each other rather than just individuals.
But isn't that the system today? I mean, I know my company, it's the same premium for the baby boomer as the millennium for a single person.
Well, I think the failure, though, in terms of, if we're ready to call it a failure, but the difficulty in the creation in the Affordable Care Act of this system that we have now, and it's called the Affordable Care Act, but it's anything but affordable. The idea is that I think we all believe in access. I do. Everyone on this panel believes in access, and people should have access to quality, not just any health care.
That's right.
Quality health care. But the idea is that, you know, you have access to a Mercedes-Benz, but it doesn't mean that you can afford to buy a Mercedes-Benz. So if we need to not only provide the access, we need to figure out a way of making it affordable. Insurance, traditionally insurance, and the lifeblood of insurance is that it needs to be experience rated. So if you have a system, and I'm not the expert on insurance, but if you have a system where you're providing coverage at the same cost for someone who's going to be using healthcare a lot more, as opposed to someone who's not going to use it at all.
But don't we have insurance experience-rated coverages that companies, all corporations are paying experience?
That's in group policies, right?
Okay, but I'm talking about the group policies are experience-rated.
We do everything. So large companies are self-insured, and they just figure it out on their own experience, and they're all different. So if you're Circuit City and all you have is 28-year-old young males, your insurance rates are very low. You know, if you're a company that has mostly older people, you're going to pay a higher rate.
In addition, when you're being group rated, you're in a position to try to control your experience to some extent. So you do certain things like wellness programs or incentives for people to...
But don't we have that right now? You're on the board of Montefiore also. And Montefiore has received additional monies from the government under keeping people healthier, correct?
Yes.
What do they call it? What was that program called?
There's a couple programs.
Right, but you know, there's one specifically that they got additional capital.
Yeah, it's called disproportionate share.
Right.
You have a disproportionate
So
share
if you
of
keep the
Medicaid.
people healthy, okay, that's part of it.
Yeah.
But you know, you brought up the point of the competition. The amount of money that is being spent in the form of advertising, I think it's, I mean, 25 years ago, you didn't have every hospital system advertising. And what are they advertising? They basically all have good doctors. They have good equipment. As Harvey said, you know, fine, one has the state-of-the-art that's 3 days old. It's not the same thing. But in the city of New York, we have 4 or 5 very good systems, okay? But all they're doing is spending money on other expenses.
It's a capitalist system, and we really, really believe in that.
But why do our neighbors in Canada work relatively well with their type of insurance? Which is, Harvey...
They're probably not as much of a capitalist as we are. And when you do stuff like that, it means that you're going to have duplication. There's supply and demand, I don't think, really works in healthcare. The demand is, you know, determined by the physicians, and the supply is determined by the physicians.
But okay,
so
since
you don't have
since we're in a capitalist system, how do you get doctors to become doctors? How do you get people who are in medical school, you know, who are undergraduates, who say they want to be doctors? At one time, many of them wanted to be doctors because they wanted to be entrepreneurs. In today's market, many of them are not entrepreneurs. They work for a hospital.
Right.
Yeah, but the idea that individual patients will make wise choices depending on cost has never really been proven. They are so vulnerable when they're looking for services.
But you know, we also ought to address the fact that a lot of the docs come out of medical school with huge debt, and they've got to find a way to pay that debt back. And of course, you know, necessity is the mother of invention, and so there are ways in which they can do it at our cost to pay it back. A lot of these issues are issues that if we face them head on, the same way we face head on the idea that we're paying for everybody anyhow, so let's do it in a direct way. In the case of the docs, why don't we as a country unburden them of this great debt so they don't have to make that debt
But there
back?
are doctors,
It's all
okay,
inefficient.
and one specific one is the president CEO of Montefiore, Steve Safer, who, when he went to medical school, got scholarships, and he agreed at the end of his term to work for public service. And he spent 3 years in public service, a little longer. His public service was at Rikers Island. So, you know, that's...
Well, you know, and, you know, one of the oldest things that we learned in college when we studied economics is the rule of supply and demand. And also, there are compensatory factors that go into deciding what compensation somebody should receive. And that's why doctors were always rewarded more than other walks of life, other types of professions in our community. But we've gotten away from that. So you take a look, especially you take a look at the internist or the primary care physician, the family practitioner, who at one point, you know, when I was a child, would be the general practitioner, not only delivered you, took care of you.
At Harvey's time, they would, you know, they'd even walk with a bag into the apartment.
And they would come to the house, even in my time. But what's happened now is that when you take a look, and it's the entire system that you have to look at how different it is from before. And no one argued that the physician should be the higher paid person in the community because of what they did for the people in the community and taking care of their friends, their family, their neighbors. What's happened today, you look at the primary care physician who comes out of medical school with all this debt and 5 years into practice is making $110,000. When you take a look at that situation, you have to look at the system and say, well, what are our priorities? And when you talk about choice, the dermatologist, the plastic surgeon, the people that are the highest paid in this profession, are, you know, when you look at it, you say, well, who contributes more to society? It's really the primary care physician when you take a look at it.
We need more primary care physicians. We need more Dr. Kildares. Is it Dr. Kildare?
Dr. Kildare, right. We've seen all these new urgent care centers coming up. Even Northwell has an ownership interest in this. Are the urgent care centers really helping the emergency rooms? Are they helping our insurance? Are they cutting costs down?
You know, this is a subject of much debate.
Yeah.
I would come down on the side of the urgent care centers, but it's very close. You can argue that they create more costs because some of those patients end up in emergency rooms anyway. But
they're a feeder for an emergency room in many cases.
Yeah.
But if they were under a coverage umbrella, Mike, we wouldn't need as much of the urgent care. Yeah. We wouldn't need the emergency room. They would have wellness.
But I'm sitting here and
we would deal with
and I'm not
everybody
saying
in a more
I could fix
way.
it. But I'm hearing, you know, in the city of New York, where you have more health care than anything else, you know, than any other city in the country, we're not resolving anything. The only thing that I know is that my premiums are going up for everybody I know.
Yeah.
There's not a reduction in premium. The only way you have reduction in premium is you have this major deductible, and certain people don't, you know, it's the question of utilizing it.
Does anybody in this room remember Rube Goldberg?
Yeah, sure.
Okay. That, to me, is what our healthcare system looks like.
It's a Rube Goldberg.
And the real problem is nobody's in charge. The doctors aren't in charge. The government's not in charge. The hospitals aren't in charge. I think the real issue is it's a value discussion that we've just never had.
Right.
Yeah. But your point about the nation's character is a very important one.
We've never decided that healthcare, you know, like everybody agrees they're going to pay money for police protection or fire protection or schools. We've never decided as a country is healthcare something everybody should get. We just haven't, and we need to get that discussion over and get it resolved.
And my point is that I think it not only makes good social sense, but it makes good business sense. Yeah. It's better for the country And in a global economy, do you remember those ads years ago with Lee Iacocca when he was at Chrysler? And he was talking about the fact that it cost Chrysler more money for health insurance than it does for steel. And how are they going to compete with, at that time, the Japanese were really
but let's,
big threat.
let's go back to the Kaiser program, to the original idea of Kaiser, which has worked well in certain parts of the country.
Good example.
Why can't the Kaiser Permanente model,
Yeah.
Where the doctor is a salaried employee, where the coverage, where you go to the doctors, where there's an incentive for people keeping the costs down, correct? They're working together.
And by the way, that whole model really came out of the World War II effort.
That's why I'm bringing it out.
In order to make it efficient, in order to be able to build ships in the most efficient way.
When everything good happened back then, right?
Yeah.
Yeah.
Well, that's how they.
The problem, Kaiser has tried to travel. They've tried to tried to start up here. They tried to start.
But they've done relatively well. They continue to do well in California.
And Colorado.
And they've done well in Colorado.
The real problem is they have to get to scale. So they have to get large enough so they can control hospitals.
Right.
And they have
but
to
they own their own hospitals.
Yeah, but when you start up in a new
not
market,
everywhere.
you
Not
have to
everywhere.
have enough
In California,
business to
they
fill up
do,
a
but
hospital.
not everywhere. What Mike is saying is they've got to be able to replicate California, which
So
you
what
can't
happened?
do
So what
just like
happened?
that.
Let's say, is it 30 years ago? What happened to the HMO model? What happened? That was a here. You remember
Well, in a
United
way, you
Healthcare.
kinda-
That was the initial.
Yeah, but these narrow networks are going back. This so-called new invention of a narrow network is really, it's what it's going back to the future. It's really.
I think you have to say, having made my living in the HMOs for a long time, that it's probably a failure. When you look at, in 73, it was cast by Nixon as an alternative to Edward Kennedy's National Health Insurance Program. And, the fact that we're at 17% gross national product, I have to say, it hasn't controlled costs. It really hasn't. And we need to look at something else.
Well, I think the HMOs really, they just got caught up in the fact that people wanted choice, and so they kind of moved away from what we knew as
big country.
the HMO.
I mean, one of the problems is we never got across the idea that everybody should have insurance. Even if you're young and you don't anticipate insurance, you should pay because then your parents who are older and maybe sick
but here's
can afford insurance.
But here's a question: since you were at the beginnings of the HMO movement, and you were in the employment business before you were over there, and you had companies. I mean, you were multi-plan. How many people, white people, go to the HMOs? White employers go to the HMOs, and why do their employees go to the HMOs?
As I recall, the big thing was not simply cost, but it was the idea that HMOs really marketed wellness. They marketed the idea that they were going to take.
So I'm hearing that today. Wait a second. They marketed the approach that you'd have everything under one roof.
Yeah.
You have a cost containment and a certain price. You knew where you were. You would have doctors who were part of the network who really wanted to take care of you, right? This was all of that. So that was then, and as you just said, and it's true, you don't hear about, with the exception of Kaiser, the HMO movement is basically...
Well, I mean, if you take HMO, that's because it's kind of taken over everything. Every insurance product has a defined network where you contract for cost. And if you have indemnity insurance where you don't have a network and you just pay whatever the doctors charge, that has competitively disappeared. It just isn't in the market anymore.
That's right.
Nobody sells, and maybe somebody does, but nobody really sells indemnity insurance. So it's certainly better, than the old indemnity policies that everybody used. I mean, that's really disappeared from the market.
Yeah.
And I think the costs would be even higher if we hadn't done that.
Indemnity, as I recall, Mike, existed at a time when benefits were scheduled. I remember when I first started at Amalgamated Life, we had a surgical benefit schedule. That's what we paid, period.
But wait a second.
We had a diagnostic
Hold on.
Absolutely.
Don't you have, the DRGs have left? Didn't you have that diagnostic-related codes that when a certain thing that you got paid a certain dollar amount based on a procedure? Don't we have that today?
Even if you looked at that, it started with Medicare. But even
Medicare.
if you look at that, I mean, this is part of that 70-year experiment of trying to contain cost. And looking at it from the hospital's perspective, I was in New Jersey at the time. I worked in hospitals in New Jersey. New Jersey was the first state, to my recollection, that had DRG reimbursement statewide. Now, there had been a little bit in Maryland, and it came out of Yale, the concept of it. It was a very good idea in terms of trying to contain costs. But the hospitals that learned how to live with DRGs prospered. And some of them did extraordinarily well, even better than the old days of daily rates and retrospective payments. But with the dawn of DRGs, if you didn't have a good finance department and you didn't have a good revenue cycle department or whatever it was called back then, you failed under DRGs because you didn't know how to manage. You were used to making money on increasing length of stay, not decreasing length of stay.
That's right. I mean, but let's look at the length of stay today. 10 years ago, the length of stay was probably 7 days or 8 days. What was the length of stay?
4.5, 4 days.
Right. And today, you know, people are in and out. Okay. The ambulatory surgery has changed. I mean, we never really had ambulatory surgery to this level. So how do you, I mean, I'm not saying that this group of distinguished leaders could come up with a panacea to resolve this, but how do you see the future? I mean, do you get rid of Obamacare? Do you make changes that the hospitals share more of the losses? You know, what do you do? Do the doctors?
Well, the traditional solution is that, which doctors and hospitals don't like, is you capitate them so they become risk bearers and small insurance companies with, you know, stop-loss backup from the big insurance companies, and you give them a fixed amount of money for every patient. And that is really hard to get a hospital to do, and it's really hard, particularly to get the innards of the hospital, the specialists and the surgeons, to accept.
I think Mike's point earlier, though, I want to go back to it, is the idea that the character of America is such that it really makes us different than all these other countries. But I think working within that character, the idea that healthcare is a business, the idea that you take all the companies that are in the business now, they've only grown up over the past, I don't know, what, 30 years? I don't think Aetna was in the health insurance business 30 years ago. I don't think Cigna, you know, maybe 30, 35 years ago.
They were in insurance business. And
they were in a different,
but they weren't in the health insurance business. Right, yeah. And they all sort of gave up. Aetna gave up their property. They were a 150, 60, 70-year-old old line insurance company, multi-line. They did everything. I think health was like a stepchild. And then they gave up everything and went exclusively into health because that's where the money was. That's where the premiums were rising. Life insurance premiums were going down. Auto insurance premiums were kind of stable. Health is where all the money was.
So
Cigna was, what were they? They were Connecticut General, which was life, INA, which was property casualty. They merged together, and they gave up the life, they gave up the property casualty, strictly health. That's where the money was.
30 minutes is insufficient time to talk about resolving the healthcare system. But at least I believe we've given some insight to my viewers on some of the problems and why these problems have taken place. I'd like to thank Mike, Tony, and Harvey, and I'll see you next week.